Coming up on this episode of Healthy Longevity.
Medical gaslighting is real. Our colleagues tend to, unfortunately, not listen to patients. We've lost that art.
Testosterone goes way beyond just sexual health. Actually, energy and cognition and memory and muscles and bones all are important.
Combining testosterone plus GLP-1 as the best 1-2 punch for metabolic disease.
I've always reversed diabetes without ever giving anybody insulin, ever.
Only 7% of Americans are metabolically healthy.
I have to tell you that I've never seen a completely healthy human being. Hello, and thanks for joining us today for the Healthy Longevity Podcast. I'm Dr. Florence Comite, founder and CEO of Comite Center for Precision Medicine and Healthy Longevity, with offices in New York, Palo Alto, and Miami Beach. I've actually been prescribing peptides like the glucagon-like peptide 1 or GLP-1s for over 2 decades, before the frenzy hit a few years ago when Ozempic was introduced and celebrities started getting prescriptions and talking about it. But even I didn't fully appreciate the potential of these game-changing medications in their earlier forms, but I saw that there was a huge upside by trying it even myself. More on that later. Today, it seems that every couple of months, we hear about new applications for GLP-1s. Researchers are exploring the potential use for inflammation reduction, treating alcoholism and other addictive behaviors, and even dementia and mental health. There's much to explore, so I'm really delighted to welcome today's guest, Dr. Rudy Eberwein, founder of A New You Wellness in Miami, Florida. A hospitalist for over a decade, Dr. Eberwein now specializes in preventative medicine with a commitment to helping patients achieve lasting health through weight loss and wellness programs. Rudy focuses on hormonal optimization, human performance, and longevity, while exploring innovative treatments in functional medicine and introducing therapies that address the root cause of disease. If you have questions about the benefits and risks of GLP-1 medications and hormonal optimization, you're going to just love today's podcast. Rudy is special. Let's jump right in. Hi, Rudy. I'm so glad you can join us. We had dinner in Miami a little while ago with common friends, and I was so delighted to get to know you. And you shared your background with me, how you studied, where you came from, and that you have plans for the future. I'd love our listeners to learn more.
My pleasure. And first, I have to say, Florence, it's truly an honor and a pleasure for me to be here today, because I remember getting your book, Keep It Up, almost 10 years ago, 2013, 2014,
Right.
Because it is one of the books that really helped me get into that path of preventive medicine and men's health specifically. So I'm originally from Haiti, and I actually came to the US at 21 after I did my first year of med school in Haiti. And I came here to start over from scratch because I really felt that there were a lot of political problems in my country. So when I came here, I went to University of Florida for undergrad, University of Miami for med school, and I ended up going into internal medicine. But I did acute care medicine. I was doing hospitalist medicine the first 10 years of my career, working the ICU, emergency room. I carried the code beeper, and it was grueling. Loved what I was doing. And I have to say that conventional medicine is really good at acute care medicine. We're not good at preventive medicine. And that's what, with your precision medicine, that you've really opened the world for all of us who are looking at this that way. So after I finished, I wasn't satisfied with acute care. I decided to go more into preventive medicine. But even as a primary care doctor, my training did not prepare me to really help patients with not just not getting sick, how to help them thrive. I would get guys who come to me. It's already difficult to get men to go to the doctor. But they come and see me, they're mid-40s, 50s, their wives or girlfriends brought them there, and you do their basic labs. You're like, okay, yeah, your cholesterol is a little high, your vitamin D is low, see you next year. And then you see them kind of, but doc, I don't feel good. I feel like I'm quote unquote old, I'm tired. Well, your labs don't show me anything. Maybe you're stressed. See you next year. And then I found your book. Then I found like the type of physicians like you said, there's something deeper than this. And I started going into the testosterone world and seeing that what I learned in medical school, that low T only happened to old guys, late onset hypogonadism, or if you've had cancer or chemotherapy. But besides this, don't even check testosterone levels. And then we see that it opened up my world, that we see we can really help guys feel their best, not only feel and look better, but really affect their overall health and their cardiovascular disease with the right treatment. So again, thank you, and such an honor to be here.
Well, that was great. Of course, it made my week, maybe my life, my month, because that book was very hard. It was the first time I wrote something, and I picked men particularly because there was nothing out there. But even back then, people laughed at me. No one even heard the term precision medicine. They didn't understand why proactively you could turn around someone's life and change their health destiny, their future health destiny, because testosterone goes way beyond just sexual health. Actually, energy and cognition and memory and muscles and bones all are important. Testosterone is critically important for all of that. So you went from conventional hospitalist, which is acute care, and I agree, when you hit the wall, that medicine saves your life. Sure. Break a limb, you get it fixed. But as far as probing beneath the surface and seeing what's going on in an individual, that's just not happening. And it's hard to understand why. I actually thought, as I started seeing numbers in people who were like 30s and 40s, and I saw emerging disease, high cholesterol, high sugars, insulin resistance, low testosterone. As an endocrinologist, and particularly trained in reproductive endocrine besides adult and pediatric, so I had a triple appointment at Yale, I was in a unique position to showcase why do we all begin to decline in our 30s and we don't feel well. And it's all happening at the cellular level, and our genetics start having a bigger bearing on how we represent who we are, what our cellular tissues are saying when we hit our 30s. We can burn the candle at both ends in our 20s and survive, ski all day, play cards all night, drink, and still hit the slopes. We can't do that when we hit our 30s and beyond. And that's really what drove me. How do we keep our health instead of losing it and then declining as we live longer and longer lives, but in terrible shape? So I'd love to understand what your particular wellness center does and what you're doing to focus on preventative health.
Yeah, so great. So I actually first went into that world because of my wife when she had premenopausal symptoms at the age of 42, and none of my gynecologist friends could help me. She was exhibiting the typical signs of premenopause: anxiety, she couldn't sleep, she was gaining some visceral fat, her FSH was pretty normal. So they all told her, nope, it's not premenopause. The same thing that Oprah said in the menopausal revolution, Halle Berry, that came in and said that they thought she was crazy because anxiety is a very prominent symptoms of premenopause. I had to go all the way to Orlando to see a doctor who did what at that time we called it anti-aging medicine. We don't use that anymore. You know, whether we call it age management, anti-aging, optimization, lifestyle medicine, precision medicine, which I love that term. At the end of the day, what we're trying to do is optimize physiology. And I think that what you've done in your book, what it has helped countless of us physicians who are coming now, is to understand molecular biology and physiology at a cellular level, and to understand that one size does not fit all. And we need to see, my wife was the perfect example. Finally, when she found the right doctor who did the right testing and listened to her, to say it wasn't just in her head. Medical gaslighting is real. Our colleagues tend to, unfortunately, not listen to patients. We've lost that art. So my biggest pleasure, especially now that I don't take insurance anymore, is sitting down with my patients and asking them questions. You know, me and you, when we met at dinner after the AMMG, I loved that you were asking me questions about my family history, about what we call the exposome. What does my family history say about me? What does my history of exposure say about me? Because that affects our epigenetics, that then affect our hormones and affect our overall vitality. So once I finally found that doctor who took the time and treated my wife, and it changed her life, and it changed my life. And I was like, wow, there is something different. So I have to really unlearn almost everything I learned in medical school when it comes to hormones and relearn it. And that's where AMMG really had a big part of my life, because I went and studied and I became board certified with AMMG. And it really opened my world that, my God, we barely scratched the surface in medical school. I was lucky that my undergrad major was in food science and nutrition, because we barely get 6 hours of nutrition science in medical.
I think that's a lot.
Right? For the people who are lucky. So
I have to congratulate you, because that AMG test, I know I was one of the authors of it, is very hard. And none of that information, I think we're all channeled into take care of disease, not take care of health. As you pointed out, that was the big aha for you. An epiphany that you can help people. Even after you started private, you didn't know where to go. So that was amazing that you chose to do that.
Yeah. So I started doing women's health at the time. I learned how to do the hormone replacement through MMG. I was doing a lot of women's health and men's health. And again, I had to overcome my bias that, when I went to med school in the 90s, thanks to the fear of testosterone and prostate cancer, they told us testosterone is bad. And only old men with late onset hypogonadism will get low testosterone. And then what I was seeing in my practice, guys that are in their 30s, their 40s, even in their 20s, with true symptoms of low T. And then if I just relied on my conventional training, if they didn't have a history of cancer, radiation, mumps, or they weren't late onset hypogonadism or old, they're like, don't even check their testosterone levels. And this branch of medicine, precision medicine, is changing that, because we are N of one. We are all so different and so physiologically different that as a physician, when you take a medical history, we need to keep a very broad differential diagnosis. And hormone dysfunction now should be really high on our list because of the toxic world that we live in, the exposome, the toxins, endocrine disrupting chemicals. It's a different world.
Totally agree. Can you describe a typical client? Like if you're going to pick male and or female, how do they present to you? What is the major complaint most have, and what do you do for them? How do you start?
So again, my first foray into preventive medicine is that I opened a weight loss clinic called The New You in Miami. That was back in 2005. Coincidentally, 2005 was the first year that the first GLP-1 medication was FDA approved, exenatide. So I opened my weight loss clinic. At this time, I wasn't doing hormones yet, because I always say, and it's true, nutrition is the lowest hanging fruit of wellness. If you help people change their nutrition, that's the best bang for your buck, for the wellness buck. So I started my weight loss practice back in 2005. I was doing behavior modification, nutrition, counseling, and I was using at the time what was available to us. The stimulant medication, phentermine, diethylpropion, phendimetrazine. I was doing intermittent fasting. So anything we could, and a lot of one-on-one. So when you do this, you become a psychologist a lot. GLP-1 represented a true paradigm shift in the treatment of metabolic disease and obesity. And I've been using GLP-1 medication since 2006, 2007. First one being exenatide by Durion. And I saw what it was doing in my diabetic patients. Once you had 2014, Byetta came out, Victoza, Saxenda. I used those. They weren't great, but at least that was a paradigm shift still.
With help.
2017, when semaglutide came out, that was the bonanza and completely changed my practice. So the typical patient will come to me, both men and women. I have a doctor who sees a lot of my female patients for the hormones. I focus a lot on men now, but the typical patient will come to me and tell me, Doc, I need to lose weight. I'm tired. I went to see my doctor and they told me everything is fine. I'm trying to lose weight. I may be pre-diabetic. I have insulin resistance. I'm trying, Doc. I'm really trying. But they labeled me non-compliant because my A1C keeps going up. So by the time I see the patient, I do a full evaluation, full blood test with all the biomarkers, all the hormone, including total and free testosterone, LH, FSH, SHBG, so we can have a real complete picture of what's happening with the patient. And based on what the patient did, I'm a big proponent of GLP-1. And then GLP-1 has really transformed my practice and brought miracle results to my patients. And my lecture at AMMG was specifically combining testosterone plus GLP-1 as the best 1-2 punch for metabolic disease.
I
because
couldn't agree more. Yeah.
it's,
Absolutely.
although
I
we
use
always,
Byetta also. I actually found it all helpful, but remember, I started from metabolism, carbohydrate metabolism, and hormones. So to me, Byetta and the GLP-1s was an addition to metformin and some of the other ways, because I've always reversed diabetes without ever giving anybody insulin, ever. Because to me, it put on weight and it turned certain compromise actually worse, not better. So if you could help them with their sleep and with their food and with their exercise and do restorative practices like massage or yoga or meditation, you could make a difference. And that one-on-one, that N of one, where every person needs what they specifically, precisely need, was based on data. That's where precision medicine came for me. That's what I focused on.
yeah.
Now, you've called GLP-1s the most important breakthrough since the invention of antibiotics. I say the same thing. I think it's the drug of the 21st century. Why do you see this change as so dramatic?
When you think about it, in the 1940s, when penicillin was invented, what was killing us then was infectious diseases. What is killing us now?
Yes,
Metabolic disease.
exactly.
The latest studies are showing about 93% of Americans are showing some kind of cardio kidney metabolic disease. Only 7% of Americans are metabolically healthy. This is unacceptable as
I have to tell you that I've never seen a completely healthy human being. If there are 5 biomarkers that we measure as critical, they're always abnormal in everybody in some kind of combination because of the life we live, the food we're exposed to. Even if we are well intentioned and try to eat well, even kale doesn't have nutrients, which I've been told by celebrity chefs, because they're grown to be big and voluminous and the soil is not healthy anymore. Anyway, you are saying then, in combination with hormonal therapy, you're not seeing the muscle loss that comes along with a lot of people's complaints about GLP-1s, right?
Exactly. So we need to start looking at fat, especially visceral adipose tissue, VAT, and muscle, lean muscle mass, as active endocrine organs. They are not just inert. So for me, fat before was just something ugly in your bathing suit. I live in Miami. So, bathing suits are important season. So you don't want to see that much fat. But I realize it goes way more than aesthetics. It is an active endocrine organ that secretes inflammatory cytokines, whereas lean muscle mass is the opposite. It secretes those beneficiary myokines that decrease inflammation. So, and so many studies are showing that lean muscle mass and strength is the best predictor of mortality and aging well. PNOE VO2 max calculation is the best predictor of mortality, better than diabetes and blood pressure. So shouldn't we start paying more attention to strength and lean muscle mass in our patients? Although I love GLP-1, if you lose enough weight with it and you don't do the right resistance training and you don't keep up with your protein, you will lose muscle mass. And we can do a disservice to our patients when it comes to this.
We
But for
need to be balanced.
we need to be balanced. And there are studies that show that more than 45% of patients who have prediabetes, diabetes, or insulin resistance will have androgen insufficiency. So, I know you do this, I do this, but all of our colleagues should do this. If you have a patient who's coming to you who is overweight, obese, with insulin resistance, check their testosterone. And we can no longer just rely on the conventional ranges. Because the latest ranges from LabCorp, I don't know if you've seen that, but the latest from LabCorp, the lower limit is 264 in testosterone. I had a patient the other day, came in with every symptom of low T. His testosterone was 288. And his endocrinologist told him, you're not below that 264. It's not your testosterone. That's a
And then
disservice.
if you look at free testosterone, you're getting it even lower because many of obesity pockets testosterone. And puts it away into the fat. So you have to look at that. So I wanted to turn to the fact that where do you get hypogonadism as an epidemic in young men, or, low testicular function? That would be great. And before we move into it, I just want to say how much I agree with your notion about lean muscle mass, because I consider muscle the organ of longevity. If you have enough muscle, you're going to do better in terms of health. And it's cachexia of cancer or of AIDS that allows diseases to inflame us, and we die when we have too little muscle and too little fat. So there's a nice balance in there that we have to achieve between muscle and the good fat. And that is a critical element that you seem to speak a lot about. But I'd love to hear your thoughts about the epidemic in young men with unless you want to add something with respect to muscle and maintaining that in men.
Yes, if you don't mind, let's finish because it's such an important
I agree.
message. And when you think about it, primary care docs, my specialty, whenever the patient goes to see them, especially women, they make a big deal about osteopenia, which they should. They'll send for a DEXA scan. If they have even osteopenia, they'll be quick to put you on calcium, bisphosphonates, and do this. What about sarcopenia? They never measure lean muscle mass. And sarcopenia is even more important to me than osteopenia. Both need to be addressed, but I feel like there's not enough awareness about measuring sarcopenia as we do for osteopenia.
I think there's not even the term isn't that known, but here's an interesting thing for you, because obviously I started a decade or more before in focusing here and as an endocrinologist. But when people would question testosterone and prostate cancer in men or just cancer in general, I would point out that osteopenia and sarcopenia, osteoporosis ultimately, too little muscle, is tied to testosterone. That's why men get osteopenia or low bone 10 years later than women. They have Colles fractures of the wrist because they have so much more testosterone. But women are protected more in the heart because we have estrogen, which also protects the heart. So our heart attacks start 10 years after men. And that completely escaped people. And then my last argument that I used to fall back on when I would have a urologist that I had to get agreement because I would find patients with Gleason 6 and they would be concerned. And I would say the Gleason 6 is not what's going to kill them. Their diabetes and their heart disease and their low testosterone, which causes more diabetes and more heart disease because you don't have enough muscle. And so in the end, that won out, but it was heavy going it took a long time. Around the time I wrote the book, which was 2013, that was when people started talking about testosterone. And they hadn't even heard of human chorionic gonadotropin or HCG and natural peptides to increase it. So I'm completely with you, and I'm grateful that you read the book, you took the test, and now there's other people out there like you doing such fantastic work. It really means a lot to me.
Thank you.
Is there anything else you'd like to add about muscle? Because I think you hit the nail on the head about enough protein, at least a gram, even maybe 2 grams per kilogram, or let's say a gram per pound of body weight at a minimum a day. And also you want to maintain hormonal optimization. And then the GLP-1s make ultimate sense in that situation.
Definitely.
Do you agree?
And one thing I see a lot with my women who come to do GLP-1, when I tell them to go exercise, they're like, yes, I walk. I'm like, that's good, but you need to do resistance training. Women say, no, I don't want to get bulky. I'm like, it's going to take a long time to get bulky. Lift heavy.
I don't ever see bulk.
Yes, we don't see
Right.
bulk, but they have that fear. And I'm like,
Right.
you need to do resistance training
They don't really want pecs. But they like triceps and biceps like me.
glutes now. They
I
really
work,
do.
and glutes are really good too. I can't get there. I have to get some real advice about the glutes, but let's not go there right now. It's an embarrassing subject. My niece complains her whole life that she has the Comite butt, which is no butt. You know? I work so hard in the gym. I'm so good at lunges and squats and all of that, and it still doesn't matter. I think it's genetic. Let's move into the neurological basis of obesity and the food noise that we hear about, and the fact that so many, even those young children with metabolic syndrome who can't lose weight, who look at food and they look at their friends who can eat anything, because in childhood you should be able to. But if you've inherited metabolic syndrome, which is so common nowadays, you suffer your whole life. And the food noise that Oprah and others brought up are also of concern. And that's one of the areas that I think you and I are both interested in terms of GLP-1s.
Yes, and I think to me that is the bigger side of GLP-1 that we don't talk enough about. So, as physiologists, as endocrinologists, internal medicine, we can talk nonstop about what it does for the physiology. It improves heart health, it improves liver, kidney, brain health. But what I love that it does, it changes consumer behavior. Because I didn't realize before that obesity was not just a disease of lack of willpower. That's what we're all taught before. If you just try harder, if you just stay away from that chocolate, come on, you can do this. And what
Right.
happens?
You're weak if you don't do it.
And the patient
Right.
internalized that something is wrong with me. And then now
Right.
we realize we give a patient a shot that's a hormone that now repairs appetite physiology. And all of a sudden, this patient can do what they know they were supposed to do. That's when I realized that obesity, there's a neurobiological dysfunction in the level of the brain that really perpetuates that cycle. Because I kept saying, why are those patients coming back, still eating that cake? Is it that they don't understand? It's not. That's when I realized willpower, free will, is not really free. Those ultra processed foods, those toxins have been shown to create leptin resistance and all kinds of other things with our epigenome that makes it that we cannot say no. And what's interesting, some people can, some people cannot. Oprah said the whole time she was struggling with weight, she thought that thin people just had a stronger willpower than her. And she
Right.
saw that it gave me a shot. And within 2 weeks, my willpower changed. It wasn't my control. So now you can see that by obesity is no longer just try harder. If we can help improve that neurobiology, which we haven't been able to define completely, because we don't understand exactly how GLP-1s work in the brain. We know there's GLP-1 receptors. We know there's neuroinflammation. When you have obesity, you have high visceral adipose tissue and high inflammation. GLP-1s decrease all of this, but we still don't understand it 100%. But the proof is in the pudding. When you see somebody, again, in my area, I am the guy that they refer to their difficult cases. Because by the time I put a patient on GLP-1, and if necessary, on testosterone, where their energy, their motivation, their outlook on life is better, it's easier. And I always like to say, results beget results. This patient loses the first 5 pounds. All of a sudden, they're motivated. They're waking up at 5 in the morning to go to the gym. They're saying no to that second slice of pizza. All those things they knew. It's not that the patient didn't know they had to do it. They just couldn't bring themselves to do it.
Absolutely. You're giving them that tool, that first step that they need, and then they want to do it. The motivation is back. But that is also affected by GLP-1s. I believe the seat of the master gland is not the pituitary, it's the arcuate nucleus of the hypothalamus, just as a mouthful, not for everyone might laugh at that term, but it's the where emotion and food and desire and even interest in sex, that's where it all arises. And I think the GLP-1s have a specific impact on that, as well as in the gut. And that's why it affects the gut as well.
Completely.
I'm going to change the topic a little bit. I think we touched on, some of our favorite topics, but I want to make sure I hear some of your thoughts because we had an interesting conversation about ferritin as a marker of inflammation and insulin resistance. And I'd love to hear what you think about that and iron and how that affects our health as we mature.
Definitely. So iron, I took a deep dive on iron because I never knew anything about iron. The only time as internal medicine doc I used to check iron is somebody has iron deficiency anemia, a low MCV, and I would check their iron levels. I started checking iron on my patient, including ferritin, total iron, iron saturation, and CIBC, because a lot of my patients who would come to me from other doctors on testosterone therapy, their doctors tell them, you need to donate blood every 2 to 3 months. And then I would see a lot of my patients, they told me, they're like, doc, I'm tired. I need more testosterone. When I checked their iron, a lot of them that were over donating, it's because their ferritin level was low. They crashed their ferritin. If you have low iron, low ferritin, your thyroid doesn't work well, you have low energy, your mitochondria cannot make ATP. So I would tell those patients, stop donating. Let's get your iron to get back in place. You don't need more testosterone. We need to just make sure that your physiology is better. But lo and behold, as I started checking ferritin level, I started finding a lot of patients with high ferritin. And then high ferritin is an acute phase reactant. The more inflammation you have, the higher those levels. So a lot of the patients I was seeing was mostly an inflammatory reaction. There's actually a syndrome that they describe called dysmetabolic iron overload syndrome, DIOS, that you see a lot of patients with insulin resistance that will have a ferritin level in the 300, 500, 600. And then
And
when you
independent of hemochromatosis, right?
So no, but so there's the inflammatory reaction that can just be this. But then I would see some of those patients, I put them on GLP-1, they lose weight, the ferritin goes down. But then for the patients that the ferritin stayed up, I went deeper. And I started doing genetic testing for hereditary hemochromatosis. And I found in my registry right now, I have about 60 patients that I found with high iron levels, high ferritin, that tested positive on their genes. A lot of them are one out of the two genes for hemochromatosis. And I learned in medical school that hemochromatosis was a very rare disease. It's a recessive disorder. You have to have both genes to have the disease. So when I started finding some of my patients with only one gene, but had high iron, they also iron overloaded. I sent a lot of those patients for a liver MRI, and they had iron overload in their liver. And there's an amazing study called the Copenhagen Heart Study. That's the equivalent of the Framingham Heart Study done in Copenhagen, where they followed almost 10,000 patients for 23 years. And they were able to get a lot of data about death and survival. And they saw that one measure that correlated very well with longevity was ferritin. If you had a ferritin above 600, your risk of dying, median age of dying was about 59. If you had the ferritin below 200, was 76. So there was a difference of 17 years between those levels, because ferritin, whether you have hemochromatosis or you have inflammation, is an important level that we need to follow. So in my practice now, I check ferritin on all of my patients. And I've discovered many patients, actually hemochromatosis, it is the most common genetic disorder in Caucasians. And you don't have to have
even if you're heterozygote for hemochromatosis. And also ferritin has a role in sleep. Did you see any, what do you consider the sweet spot for ferritin? Is it related? Is it different in men and women? Is it different in every decade of life? Because I struggle with that sometimes. We look for a ferritin level of over 30 to make sure a person is in as good shape as possible in terms of stores and iron stores. Do you have a different premise for that based on your work?
Definitely. So if it's a menstruating woman, if it's a pregnant woman, you want to have higher iron stores. Because especially if a woman is pregnant, you want to be sure that the fetus gets enough iron from the mother. So you want to keep higher stores. But if you look at postmenopausal in men, it's all the same. And the normal ferritin, when you look at LabCorp, it's from 30 up to 400. I spoke to a friend of mine who's a neurologist who's very big on restless leg syndrome. And he said he wants the ferritin 75 or more, because if not, it can interfere with your sleep, specifically causing a lot of restless leg or restless activity. So now my goal is about 75 to 100, 125, because the higher the iron also, there's been linked to higher rates of cancer. So you want to keep.
What's the iron levels and the ferritin levels are they different for sleep and risk of cancer and risk of early death? Because in the Copenhagen study, they use the parameter of less than 200. But now we're saying maybe 75 to 125 is a sweet spot in postmenopausal and women and men. And it can vary in pregnant women. The ferritin, the iron would first go to the fetus, not to the mother. Yes. That's why the syndrome of pica in women who are pregnant who eat dirt, because they have too little iron and they need to have iron for their growing baby. Yes. But they come last. So the baby is a bit of a parasite. The baby's going to survive. But I find that fascinating. So how do you judge that? Do you want everybody to have a ferritin between 75 and 125?
So there was another great study called the FEAST, the FEAST, where they looked at patients who had peripheral vascular disease. And they saw that the lower, they were doing therapeutic phlebotomy on those patients to see progression of peripheral vascular disease. And they showed that this is the study where it showed that ferritin was better when it was less than 100. So 50 to 100 tends to be what that study recommended. And okay. But when I speak to, and you told me that also, that ferritin can interfere with sleep. So it's like everything in life, balance. You don't want it too low, because low ferritin definitely causes problems. You don't want it too high. So 50 to 100, if you ask my neurologist friend, he'll say 75 for restless leg syndrome. So somewhere in that range. And giving blood, I now give blood regularly, and I'm on testosterone therapy, which interestingly enough, testosterone therapy suppresses hepcidin. And hepcidin is the master hormone in the gut.
Of
So
iron.
when you take testosterone therapy, it's almost that you will absorb more iron. That's part of the secondary erythrocytosis that we see with TRT. So everybody on testosterone should monitor their ferritin. Iron levels vary so much, and it's based on diet. So ferritin is the most reliable form because it's the storage form of iron. So everybody, all of my patients on testosterone or not, but specifically if they're on testosterone, should monitor their iron level, and I tell them to donate based on their ferritin. If their ferritin is in the 200, 300, I see a lot in the 3 to 400. Donate until you get to that 75 or 100, maybe the 50. Don't go below. Don't go in the 30s, 20s, because you need iron. Iron is necessary for life. So there's a new form of disease called the ferrotoxic diseases that we see that iron is the master pro-oxidant. And, we've only discovered this 20 years ago.
That's fascinating. I don't really look for DIOS. And so to find that term again for our listeners and the significance.
So it's dysmetabolic iron overload syndrome. So associated with inflammation, you'll see patients with increased visceral adipose tissue, with pre-diabetes or insulin resistance, and you'll see a ferritin in the 300, 400, up to 600. And I will check those patients for the hemochromatosis gene, but a lot of them, you help them lose weight, decrease their inflammation, you see a precipitous drop of their ferritin.
Oh, fascinating. So dysmetabolic iron overload syndrome is a term that's associated with higher iron. And the reason many doctors tell their patients to donate a lot of blood on testosterone is because they are concerned with erythropoiesis and increased hematocrit hemoglobin and the risk of deep vein thrombosis and some of those issues that lead to emboli and clots. But that's fascinating. That's really made a difference. And I'm glad I learned something new because I hadn't heard their term before, even though I always look for hereditary hemochromatosis and making sure to keep iron and ferritin in the right vein. Also, just a small point, but restless leg syndrome can be genetic as well, but maybe ferritin aggravates it as well.
Yeah, so what my neurologist, who's a specialist in restless leg syndrome, Dr. Sergio Jaramillo, down at that's what he was saying. Iron is so important for nerve function that the balance is what you need. Too low, and you can make that the nerves get overstimulated. So he likes to be at about 75, plus or minus, but too low.
Thank you. I'm going to immediately implement that. I have one final question before we have to wrap up. I want to have a word or two, if you have a theory, and you've been looking at this as well, like I have, about endocrine disruptor chemicals. Do you want to give us a little quick primer on it and the significance of it as well?
When I started looking at why are we seeing such low T as an epidemic in young men, why are we seeing so much infertility in males? Because LH and FSH are on the same tree, the HPA axis. So there has to be that our environment is causing a lot of that dysfunction of the HPA axis. Our genes did not change that much in 30 years. And I read an amazing book by Dr. Shanna Swan out of UCLA. And she wrote the book Countdown. And she was able to prove that BPA, microplastics, and phthalates affect HPA axis, even if you expose the baby fetus is exposed in the womb. So now there's a study that showed that 100% of the humans that they tested test positive for microplastics. Microplastics carry BPA and phthalates. BPA and phthalates cause endocrine dysfunction, specifically testosterone dysfunction, causing testicular dysgenesis syndrome. So that's why I said in the beginning, we live in a new world. Those toxins, including endocrine disrupting chemicals, are affecting our endocrine system. So we need to pay attention to our exposomes. We don't have a good way to treat it, but as physicians, we need to keep an open mind that somebody may have been exposed, even not knowing they got exposed. That's what is causing a lot of their endocrine dysfunction.
I agree. I've seen a lot more lower testosterone, even in young men in their relative youth 20s, which is a shock. We are actually doing TPE, or therapeutic plasma exchange, and plasmapheresis, or plasmapheresis. It's the theory of young blood for old blood, but we're cleaning out senescent cells, cleaning out zombie cells. And we're testing plastic before and after to look and see the change. That was perfect. Thank you so much. This has been a great discussion. We can go on for hours, Rudy.
Hours.
And I always end a podcast by asking a question. You're on a plane or a flight, let's say to New York, because I'd love to see you, and you're chatting with the guy next to you and his wife, and they're asking you questions because they learn you're a longevity doctor who's interested in health proactively. What's the one or two things I can do today, is what they share with you, to make me healthier tomorrow? How would you answer?
So number one, I always say, as an individual, you need to ask yourself, how can you show up better in life? So doing a self-assessment, because a lot of times patients will come to an office to come and see me. They have no idea what they want. So the first thing I say, do a self-assessment. How are you feeling physically, mentally, sexually, and even spiritually? Give yourself a score from 1 to 10. And each area of your life that you see that you're lacking, become the CEO of your own health. Go and look for the right medical partner that can help you test and help you remedy this. But it starts with you. I tell everybody, take ownership. Ask yourself, how do I feel? How am I showing up in life? How can I be better? When you take ownership, then you can go look for the right partner to help you.
Perfect. Well, that's something you and I need to talk about, I think. But I agree. I created a slide years ago for AMG that ends with, you can own your health destiny, because you can. You can make decisions. It's not about deprivation. It's about learning what's going on under the surface and putting certain activities into action. But it's enjoying life to the fullest as well. But it was really such a fun podcast. I really enjoyed it. I think you're going to make a difference in everybody's life who listens to this. And I know we will be in life working together in some way or form as we go forward. So I'm grateful. Thank you.
I'm so grateful, and truly, this was an honor. Thank you so much, Florence.
Thank you.